Well, hi everyone. Thanks for coming to today's XPC talk. So we have my friend Michael sharing with us his insights about the biomarker space and what he's been doing with his company and go-to-market strategies. And I'm excited to hand this off to Michael. Tell us a bit about yourself and then jump into the presentation.
Yeah, absolutely. So hi everyone, Michael. I'm originally from Canada. I was born and raised there, came down to California to the Bay Area for grad school. And then this is where I met, my co-founders and got started with SPEC. So a lot of my background has been in the medical imaging field, worked on OCT, optical coherence tomography, worked on ultrasound, and then worked on MRI. And this is kind of how I met with my co-founders, and we got started in this eye camera, a little bit looking to be a little bit more accessible. And so today, the goal really is to have a conversation. I'd love to learn from you guys as well as share a little bit more about what we've learned so far in using eyes as a biomarker and really using primary care as our go-to-market platform. And so hopefully by the end of today, the goal is that I can convince you that technology is really changing how the healthcare industry is being used, and more specifically in eye care. And really what my vision is we're really using the eye as the modern day tricoder. So for any of you who are Star Trek fans, right, you're able to take this device, scan it, and then it'll tell you everything and anything that's wrong about the patient. So I'll skip through these ones quickly. Hopefully you guys are, pretty familiar, but the retina, so the retina is, the back part of the eye. That's where all of the light focuses on your eye. That's what enables you to see. And so you get to see, the retina, the macula, where the light focuses. And that's the retina. So why do we think that this is an important platform? Or really because the retina, you get to see that central nervous system. That's the central area here. That's where all the nerves are, when you talk about rods and cones and vision, as well as you get to see the blood vessel, the central vascular system in the blood vessels. And you can see, so on the left one, this is a healthy one, but on the middle and on the right one, these have, some sort of disease, and so you can see where they don't look normal. And so a little bit of background or history, how our retinal image is captured. Well, things really haven't changed, right? We have the classic ophthalmoscope, this device on the left. This was invented back in 1850s and really hasn't changed at all in the last 150 years. Your primary care doctor may have one hanging on the wall. And in many cases, they'll pick it up, try to peek in the back of your eye, but it's not that easy to determine what you're looking at. About 100 years ago now, we came up with these retinal cameras. These are a much larger desktop system. This started really with film photography and now with digital photography. These are typically found, in ophthalmologist's office. And so companies like Canon, Nikon, Topcon all have these larger desktop systems that they've distributed out in optometry and ophthalmology. But again, fairly large, complicated. You require special technicians or retinal photographers to operate to capture images. Recently, with the advent of mobile devices and iPhones, we've come this new revolution of mobile retinal cameras came out around early 2000s. I think this is still a field that's developing and growing. As we see, there hasn't been a winner takes all or a single dominating company yet, and I think that's because there's still a lot of challenges in figuring out how to utilize them, how to train people, and how to capture images. And so this now the second part and really the tricoder piece of the story is using the AI in the retina. It's 2018, so about 7 years now. Google was the first one to publish out a paper, and they really sent shockwaves through both the AI community and the medical community, right? They were able to predict heart disease and other cardiovascular biomarkers through looking at the eye. And so I'll just share with you, if you're not familiar with this paper, I'd absolutely recommend you to take a look. This is really what kickstarted this new field that is called oculometrics. And so it's looking at, the ocular, the eye, and being able to use it as a biometric. Um, and so some of their predictions they were able to do here again, first image is the original image captured on a retinal camera, and then they're able to predict age, right? So you can see predicted age was 57 years, predicted age was 59 years, actual patient age was 57 years. They're able to predict gender, smoking, HbA1c, and BMI index. And this is really crazy if you think about it, right? This retinal image to us humans, there's nothing that is indicative of sex, right? Of gender, of male or female. Age, you can see some development as you go from like childhood into adulthood and then into maturity. But for a lot of these other indicators, so gender, smoking, HbA1c, and BMI, there's nothing that we as humans, your ophthalmologist, optometrist can really tell visually from that image. And so the fact that AI is capable of determining these and not just with some accuracy, it's quite accurate. If you look at their predictive versus actual, you look at their predictive values, it's all very statistically significant.
And I have a question, Michael, about I was at a conference where they let us test out more of the desktop cameras. You put your chin in it and then takes the picture, and it was predicting our biological age versus chronological age. Do you have any comments around that?
Yeah, I think this is all, from research that has come out from Google or all stemmed from that. I think it's, interesting to be able to determine what your, biological age is. You can do it also with bone scans and different things. I think for me, really, the question at the end of the day really becomes what do you use this information to do, right? How do you inform your decisions, whether it's you need to change your diet or exercise some more? Like, how do we use these insights to basically nudge ourselves or our patients into a different lifestyle? Yeah. So yeah, so I think in terms of thinking what next, I think really this is shows where we're going, right? I think age, gender, blood pressure, it's cool to know, but how clinically useful is it, right? So back to that question, how do you having the gender, the blood pressure, like if I'm close enough to the patient to capture an image of their eye, we can determine their age and gender through other means. You can, measure blood pressure with blood pressure cuffs. It'll be far more accurate. But what we are seeing nowadays has been more and more articles, presenting the ability to predict things beyond that. So looking at cardiovascular system, so predicting heart attack, stroke, or MACE, which is a mass adverse cardiac event. Looking at their neurological side, right? So looking at Parkinson's and stroke. You can look at nephrology, so chronic kidney disease. And again, the underlying root to all of this is really in that retinal image. If you remember, being able to see those nerve bundles, being able to see those blood vessels, and that's really where a lot of these insights are coming from. And really, the cool part about all of this is that you're able to capture these in a non-invasive way. And so, unlike traditional biopsies, this is non-invasive. It can be done in a few minutes.
And Michael, I don't know if you've seen the parallel research in cardiology around EKGs. like Eric Topol has given I think a TED talk last year or 2 years ago, how EKGs are able to get at the same thing. You start determining some of the biological variables, and then you pick up pathology like CKD, which those are just all like electrolyte squiggles and stuff like that. And so, are you aware of anyone actually combining the retina images, which are traditionally don't look at these markers, plus EKGs, which also don't traditionally look at these markers, but then together, like there is some new insight?
Yeah, there's a lot of fascinating research. I'm not aware of any companies yet that are really combining or utilizing all of the different sources of information. I think me personally, my viewpoint is that we're not capturing and digitizing enough of our, data. If you think of like your car, right? Your car has 100 sensors measuring temperature, pressure, wind speed, whatever it is, and it's able to diagnose things before, bigger problems arise. I think similarly, our body, we should be measuring things on a more continuous basis, whether it's EKG signals, heart rate variability, core body temperature, retina. I think we're generating a lot of data today that unfortunately we're just not capturing. And being able to use that to do preventative medicine, right? The healthcare system today is very much reactive. When you have something wrong, then you go see your doctor, whereas we can really make this a predictive system and be like, hey, these are things that are, upcoming, right? And you can see here, retina scan gives early warning signs of Alzheimer's disease. And so knowing that you will develop Alzheimer's in the near future, you know, are there ways to nudge the patient or yourself to be like, let's do more brain exercises, or let's do some take some preventative medication to really prevent things from degrading or progressing to higher stages? Yeah, that's a great question. And so, now knowing all of this promissory, the golden land at the end of the rainbow, then the really question becomes like, how do we turn this from what today is an academic research projects into clinical use, and then translate that into a product that can be commercialized and marketed, right? And so as a company, really our focus and hypothesis was around how do we capture that annotated high quality data, right? And so for example, with Google and their images, they went out to ophthalmologists, to hospital systems, and bought out their data. Unfortunately, my pockets aren't as deep as Google, and so that wasn't a viable business plan. And so we were thinking about how do we capture data in a more scalable way. And so I think in the similar manner of Tesla versus Waymo, we decided that let's go capture lower quality data, but capture that in a much larger scale, and be able to do things with a little bit lower quality data. And so then the next question became, well, what will convince people to use this? And so this is really where we were researching and finding our first use case, which is diabetic retinopathy screenings, right? So patients with diabetes are supposed to get their eyes screened every year. That's the medical recommendation of the American Diabetes Association, the American Eye Institute, of all of our medical societies. Unfortunately, less than 30% of patients get that annual eye exam done, right? And that is really low, especially when you compare it to breast cancer screening or colon cancer screening. Those screening rates are in the 70-80%, which is where we expect screenings to be. And so when we investigated a little bit more into this problem, trying to understand like why is there such a huge drop off? Why are patients not getting their annual eye screening done? What we discovered was really this archaic system, right? And so the delivery models, you need to go see the optometrist or the ophthalmologist who are, quite busy. In many cases, they're either not taking new patients, or for screening procedures, they'll push them out 8, 10 weeks out in the future. And that really stems from this lack of eye specialists, right? We only have one eye specialist for every 17,000 or so Americans. And so as a result, critical screenings are just not happening. Our patients are being discouraged. They're saying, hey, I still see fine. What's the big deal? And then they're just putting this off. And so really our approach was, how do we make this more scalable in a way that we can bring these screenings into primary care, into endocrinology, right, into our healthcare provider's hand. And so our theory was that if we're able to do something that's a little bit more portable and accessible, we refer really to this as the stethoscope of the eye, there is no shortage of healthcare staff, right? There are plenty of nurses, medical assistants, primary care doctors, phlebotomists, paramedics, just to name a few. And we're able to do more screenings. And so that's really the system that we set out to do. Our breakthrough was to create this platform we call the mobile stethoscope of the eye. And so just like a stethoscope, the idea is to make it small, portable, and easy to use. Just like a stethoscope, it's meant to be used by our frontline healthcare workers, right? Whether it's your primary care doctor or medical assistant. But it's also not meant to replace that big expensive machine. And so the ophthalmologist and optometrist will still have their big fancy machines, their OCTs, but we wanted something to be able to do that first level of triage and diagnostic. And so what we've built is a 3-part system. The first one is the imaging device. You can see one, over my shoulder over here. It's based on an iPhone, so it's quite small and portable. There is some optics and lenses in the front that enables us to capture images of the eye. Now, in many cases, your medical assistant is not familiar with what an eye capture is supposed to look like. And so we've built 2 experts in the loop, 2 systems. So the first one is this blue circle, which we call the navigation system. It's a real-time telemedicine platform where you'll get to talk to one of our experts or navigators, and they'll guide you through the procedure. So they'll tell you, hey, this is how you hold the camera. You'll move closer, move left, move right. And they'll capture the images with you in real time and also ensure the images captured are actually usable, they're in focus, and they're of the correct regions of interest for letting the patient go. Once those images are captured, then asynchronously, we've got our second specialist in the loop, which is our grader. And so these are ophthalmologists and optometrists who are able to then review the images, they'll prepare a diagnostic report, and then that diagnostic report can get sent back to the PCP. With just like a blood lab, that report will have, the patient's name, date of birth, the images captured, any observations, as well as the recommendation for follow-up. And so, as I mentioned earlier, our starting approach using patient with diabetes, we're able to increase screenings. We've shown 90% increase in screenings in primary care setting or endocrinology setting. This is really a preventative metric that they are graded on. We've been able to show this with minimal staff training. It's a 1 to 3 minute exam, so minimally disruptive to their workflow, and we can train a lot of their staff in under 15 minutes of virtual training. Now, what we've seen on the other side is actually on the ophthalmologist side, we are seeing a decrease in ER diversion, as well as an increase in revenue for ophthalmologists. So for ophthalmologists, previously when they were doing screenings, they're only getting paid, somewhere between $50 and $100 for that patient to do the screening, whereas now we are capturing a lot more patients in primary care, identifying patients with uncaught disease, and then sending them to ophthalmologists for treatment. And so in that same patient slot, by doing treatment, whether it's injections or laser surgery, the ophthalmologist is able to increase their revenue as well. And so, when we started to look at the patients with diabetes, it was really start with the lowest hanging fruit, right? Where's the biggest pain point? I think part of that conviction was looking at HEDIS and the Medicare Shared Savings Plan. So, where are those quality dollars being spent today? Where is the healthcare system currently underperforming? Right? These are the top 5, 10 metrics that the healthcare system is tracking today is, diabetic eye exam, A1 is the blood pressure in range, it's medication adherence, it's checking that the A1C is below a certain level. And so that was one of the big gaps that we had identified and that we understood, hey, there's money to be made on both sides, both for providers, for our insurance and our payers, but as well as for us in helping the patients. And at the end of the day, also helping the patients with preventing blindness, which, as I mentioned earlier, if it's caught early, it could be prevented. So these are some of the reimbursement incentives that we saw, at least in 2024. Not sure how many of you are familiar with HEDIS and incentive metrics, but UC Davis did a study a couple years ago on a pure CPT basis for the diabetic eye exam. They're only getting paid about $20 per patient, but on that incentive, so increasing diabetic retinopathy screening through the MSSP, the Medicare Shared Savings Plan, through the Medicare STARS program, they're getting an additional $43 per patient. And so that's a pretty large gain, right? And this is, again, for 2024 numbers, these were the star ratings. And so moving from, 30, 40% where we are today at the national average and moving that into the 60 or 70% range, like you can move up 3 stars, 4 stars and get quite large quality bonuses. So I'll just take a pause here. Any questions to date? I know I'm sharing a lot of information.
I can always ask a bunch of questions, but I'll let others think on it in case someone wants to go first.
Yeah, I can go first. First of all, this is all super fascinating, and thanks for all the transparency and sharing everything here, Michael. And I actually had a chat with Paulius a little bit ago just about reimbursements and CPT billing and codes and things like that, because especially as somebody in medical school right now, that's not something that we're taught, and we're kind of thrown into the fire, of course, once we're in residency, once we're practicing and whatnot. So for someone like yourself, who might be approaching it from a different angle from, healthcare as, being not a healthcare provider, how did you first get to be knowledgeable about all of this CPT billing and learning this, not only nomenclature, but being able to design part of your go-to-market strategy and revenue generation around these metrics?
That's a great question. I think it's approaching things with curiosity and talking to everybody and anyone. There's a quite large billing and coding ecosystem and consultants that exist, for better or for worse. And so just being able to go to conferences, go talk to providers and be like, hey, what are your issues? And really understand where are their pain points, but also understanding what motivates them, right? And so it's like, well, we are asking today primary care doctors to do 1,000,001 screening programs and 1,000,001 things and tests, but it's really understanding, well, which ones are they willing to adopt, like which ones actually motivate them from a, you know, do good for the patient perspective, but also from a financial sense. And so this is where we started to learn a little bit more. And then the deeper you get, you get to understand where the codes are, the reimbursements, and really where the quality money is going towards.
That sounds great. And if I may, a quick follow-up. I'm curious about where you kind of found the maybe thematic saturation of, talking to providers to uncover these nuances. Was it, in the tens? Like, were you seeing it at like 30, 40 folks, or were you really having to get into the hundreds to kind of uncover some of these findings?
They become quite apparent quickly. That having low diabetic retinopathy or diabetic eye screening rates, shows up in low numbers and times, but really to understand what the nuances are and where the motivations are, that took a little bit more time. Right. The other approach that we took was also working with a lot of the professional societies. And so I've been, for the past few years, we've been working with the American Diabetes Association. We've had extensive conversations with the American Academy of Ophthalmology, American Optometry Association, and understanding where they see the problem and where the solutions are, because the other thing you don't want to do is piss off one of these societies. That could be the death of a company if they start lobbying to the FDA, and we've seen that happen with a couple other startups in the past.
Awesome. That's great. Thank you so much.
Absolutely.
Michael, I had a question around now there are algorithms approved for AI diagnosis of diabetic retinopathy, right? And some companies are using that instead of specialists. What are your thoughts there?
Yeah, so I've got a couple slides on this. We can touch on this as well. So yes, there are a lot of competition today. It's still very much a fragmented system. For SPECT, we've taken more of a vertically integrated system. So, when I talk about a fragmented system, there's the camera manufacturers, right? So Nikon, Zeiss, that sell into ophthalmology today, and they're like, hey, we can sell into primary care as well. But they're still using, they still require CapEx. Their cameras are quite complicated to use. They require training. And as a result, there's a pretty low image completion rate or success rates, about 60%. SPECT with our telemedicine system, we're closer to 95%. And so instead of 1 in 3 patients that go home inconclusive, we're at 1 in 20. So to answer your question, yes, there are a lot of new AI systems. There's only been 3 of them that have been approved through the FDA to date. And the FDA has given quite narrow indications. And so they're able to give a refer or not refer for diabetic retinopathy. But that's it, right? And so what we've done and what we're seeing others do is still using human eye doctors or grading networks, as that's able to give a little bit more flavor on the eye diseases that are captured, whether it's diabetic retinopathy, and then give a level of staging or urgency. So whether it's you need to go see a retina specialist in the next month, or is this just monitor this with your optometrist in the next 2 or 3 months. The other thing that we've been surprised with is that we're catching about 10 to 15% of our patients have some sort of diabetic eye disease or diabetic retinopathy, which is right in line with national statistics. But what's been our biggest surprise is about 25% of our patients actually come back with some sort of other eye disease, whether it's glaucoma or cataracts or AMD. And that's been our biggest surprise, both to us and to our customers. These patients were able to catch these in the earlier stages before the patient has any symptoms. So they're still seeing 20/20. They didn't even know that this was happening. And we're able to get those patients to specialty to get treatment and monitoring for those conditions, right? Using the AI solution, the AI would have been bound to say they are negative for diabetic retinopathy, but they cannot flag anything else that is happening. And so this is why, yes, there are AI solutions that are coming out. I think we'll need to really work with the FDA and understand where their concerns are to be able to expand the indications before we'll see a larger adoption of AI. Sorry. sorry, so hopefully that answered your question, Paulius.
Yeah, totally. I think it's very fascinating to think about how, you're almost like representing the primary care perspective from the eyeball, vantage point, because you want to try to be a bit more comprehensive, which makes sense.
Yeah.
I did have another question around it's cool that you can really employ any level of training who is clinical staff, right? People who are MAs are able to do this. You know how what companies like Care are trying to send devices to people's homes, right? To be able to look at the eardrum and whatnot. Do you see that happening where it's a lot more direct to consumer and maybe just utilizing own devices of, like an app installed on the phone can capture actually pretty high quality of image?
Yes, absolutely. And I think you're, like reading into the future, but to today it is still a prescription device, and so it needs to be used under the supervision of a physician. But our long-term vision is absolutely to go in the at-home market, similar to Care or similar really to your blood pressure cuff, right? If you think about the story of the blood pressure cuff, it started in the physician's office, and then 20 years ago we had these really big clunky machines into pharmacy, and then it wasn't until 5 or 10 years ago now that we're starting to see blood pressure machines be authorized to be sold over the counter, and now I've got one in my medicine cabinet. And so for SPECT, we're seeing the same pathway to market. So today it's exclusively done in ophthalmology and optometry. So as a first step, let's figure out how to move this into the primary care setting. And then this is where we are today using this, 1-to-1 ratio. So patients need to see one healthcare worker. They're talking to one, telemedicine person, and then it's getting graded by that one specialist. We are now working through our first level of automation, so using some AI and auto capture guidance and capturing those images, but still requires that healthcare worker to be there with the patient, as well as in the future using some AI for the image grading. But really, the large, the big vision of SPECT and long-term vision is to expand, first into pharmacy in a, more supervised control manner, and then eventually in the at-home market. So having this in your medicine cabinet. Today I have a strong belief that this could be used at home. It's not that dangerous or that complicated. As you mentioned, we're using medical assistants, we're using EMTs. They're really, they're healthcare frontline workers. They don't have that high level of education. They do have some comfortability of working with patients or working close to patients, but that's the long-term vision. So a couple other learnings I wanted to share with the system. So one thing that we've also done is really listening to our customers and listening to the market. One thing we've seen is from the leadership team, right, really trying to understand what is the clinical workflow, how do we integrate into the workflow in a seamless way. And then what we've heard from a lot of these clinic managers or chief medical officers is that they don't have any visibility into the program success until the end of the year when they get the results back from the insurance company. And then with our fragmented systems, a lot of blame, right? So the graders who have poor gradability will blame it on the camera. Camera blames it on the staff that don't have training. And so how SPECT really differentiates is we've really created a holistic model, so vertically integrated, and we're able to give that feedback back in real time. So we share a reporting suite, right? And so on a monthly or quarterly basis, we'll get on a call with the leadership team. We'll say, hey, this is how many patients we've screened. and this is how your patient population looks like, right? Half of them are healthy, a quarter of them have other eye disease, 10%, 15% have diabetic retinopathy, and we had, 5% of them that were inconclusive. And, and these are the reasons why those exams failed, so that we're able to give that feedback in real time and iterate and increase their success rate. The other, piece that we had seen is some of our customers were asking about patient education material. And so it created these patient pamphlets in different languages to just help patients understand what they're getting and getting them a little bit more comfortable with, the need and the necessity for these exams. And so, yeah, I think that's kind of the presentations. Like, there's a lot of information that we're capturing today. And, my question to all of you is like, how can we leverage this information, right? And I think Polly's kind of hinted at some of these. How do we partner or work with other companies that are capturing other subsets of data, whether it's from the cardiovascular side or the, continuous monitoring side or the blood side, and aggregate all of that data to be able to give better diagnosis. And so at SPEC, our vision and mission really is to prevent unnecessary blindness, and then over time is really build this tricoder for diagnosis, and be able to nudge and change people's habits through gentle nudges and telling them like, hey, look, this is what you're walking towards unless you start to change something with your habits.
Really cool. I had appreciate you, walking us through your thinking in this space. So one thing I think you didn't quite touch on that maybe you could share is like your actual strategy of getting to offices and people that, utilize your devices, because there's lots of ways to go about it, right? Like physician offices are hard to get to. And so are you able to talk more of like how that outreach strategy evolved and what's worked for you?
Yeah, absolutely. So, for us, we started back in, late 2019, early 2020. It was perfect timing. I know we started mostly working with, physician offices, family offices, mostly through, friends and network. We'd be like, hey, can you use this? Let us know what you think. We want to understand how it works with your clinical workflow. As all of you know, unfortunately, COVID hit a few months later, and so we had to really change our care delivery model. That's when we started to do more at-home care delivery. So partnered up with medical transport companies, with paramedics to do these eye exams in the home care setting. That's really when we discovered that insurance companies have incentives to do these eye exams. So how those contracts worked was that the insurance company would tell the the home care delivery company, like, hey, we'll give you X dollar per patient visit. Go and see these patients and do a bunch of tests on them, right? The blood pressure check, do blood work for labs, do a mental health assessment, and part of it was do the diabetic eye exam. Because those patients were in many cases, elderly, they were geriatric, and had not had chance to interact with a traditional healthcare system or been able to go in to see a PCP in the last, 3-5 years in some cases. And from there, we, started to look more into larger systems that were, as I mentioned earlier, like follow the money, right? And so this is where we're looking at larger systems that were taking on risk, those that would benefit from quality, things like that, and then also started to target some of the insurance companies. And so, that's where we started to grow. We've got a couple partnerships now with larger healthcare systems, trying to deploy this in similar, rural areas in healthcare deserts. We're working closely with, FQHCs now. This is, as I mentioned earlier, right? You're following the money. That's when you kind of see, oh, there's, all of the HEDIS and MIPS and MSSP, like those are for Medicare Advantage plans. And so that's where we've been focusing a little bit more. And then it was until probably a year or so ago that now we're also focusing on the health insurance plans. And so we have a couple of them that partnerships that I can't disclose of just yet, but we're working with them. They're paying for the solution, and then they're the ones distributing it out through their networks. And so that makes it easier for us. So we're not trying to convince the primary care doctor that this is something they should be doing. They're getting a solution, and they're almost being told to do it by the insurance company.
And PCPs like famously love doing what their health plans ask them to do. And I so actually, like, one of the questions I have about that model where you're distributing through payers is, like, oftentimes in disintegrated systems, a provider will accept many health plans from several payers. And so what you're saying is you're giving the payer this thing, this device, and the payer is then giving it to their providers. Is the payer allowing the provider to use it on all of the patients in their panel, or just the patients who are members of that payer's products?
Yeah, so great question. I don't know if you're being sarcastic earlier about PCP.
I leave it to the reader. Yeah.
But yes. So in our cases, the health plans are distributing this out to their PCPs. They aren't restricting it to only their patients. Obviously, there's still a duty to care and give the patients the care that they need. The preference is to, prioritize their own patients, but if the doctor or the clinic uses it on a few other patients, then so be it. At the end of the day, it's like, how do we improve quality of care for everybody? The other thing too that we've seen, with one of our payers is they'll give patient incentives as well. So they're giving, gift cards to the patients, so to go and get their preventative measures done, which has been interesting for us to learn. That it's like the payers value of each of these diabetic eye exams completed is much larger than the cost of paying for it for us and paying their providers for their code, and they're still have money on the table to give some to the patients. So
have you thought about distributing through pharmacies?
We have not. I think it'd be an interesting way to explore. I think at the end of the day, it's like, who's accountable for those quality measures and getting the gap closed. And so I think today where we've seen this, it's mostly been in the primary care setting or in the health plan side.
Do you see any major threats to like the space? For example, Clear, the TSA pre-check scanners and all of that. Like, is there ways where some of this is just going to get more co-opted by consumer products, or even like those full body scans where people can just get into it and then know all the issues?
It's possible. I mean, I'm not opposed to, seeing a greater adoption and through whatever channels possible. I think that, Clear and these full body scans still target, the more affluent population that have access, that live in cities and near large medical centers, rather than, a more vulnerable Medicare, Medicaid population, elderly population. The other thing too is that at least in the US, right, the FDA will still have a very strong hold on healthcare and what you can claim as diagnosis. whether it's through screening or other things. Now, there is some overlap, right? I mean, we've now seen Apple, I think, is the first consumer device that really got that indication to do, heart rate variability and AFib. And so there is going to be more increased access to care through different pathways that are, you'll call them non-traditional pathways.
Yeah, very cool. So I think we can pause our recording here and